Excited to be here this morning. Is that too loud or are we okay? We're okay? For once? Oh, it needs to go higher? No, okay. I was hoping you were going to tell me to talk louder. So, y'all, this is one of my good friends and colleagues. We work together with the Right Here Ministry. It's Dr. Kurt Merkels. I've known him for over 11 years now. We've been working together. He is a he's only a triple board certified geriatrician. He doesn't have the fourth one yet. And he, the most humble guy on the planet. He works in some very big spaces, doing some very big things nationally. Works with Medicare, and he's co-chair of one of the big committees, steering committees there. He manages one of the largest hospices in the country. Just a wonderful, wonderful, good Christian man. So I'm very excited to get it happen here today. He's going to be talking about some key things for managing medical conditions as we age. And some of y'all. Okay. And then we'll get to also asking questions. We already have one medication list that was turned in. I remember I said, hey, y'all remember bringing a medication list? And I'll have to look at, are there some already? Love it. Love it. We're not going to photocopy these again, Doctor. So he's going to, oh goodness. You tracking? Okay. No, that's good. We don't. So he may deal with some here, and then we're going to do some Q&A in there while we're eating. Okay.
Sound is back up.
Okay, yep, we're up. Good morning. I'll go ahead and take off. I'll take a few of these. We can scan through those as we speak. Happy to be with y'all this morning. I hope you find the discussion helpful, informative. I think these 7 things that we're going to talk about are going to sound really basic. They're going to come across really basic. Especially when we're dealing with very complex medications and conditions. I can't begin to stress enough how often these basic components that we're going to talk about are not attended to, not done, not covered, and often lead to significant problems and complications as we age and as we get older. It's astounding the number of hospitalizations and complications that are a result of adverse events that occur from medications. It's astounding the amount of times we see medications and treatment plans that are not being, it's not necessarily not being followed, it gets lost in translation. There's so many different doctors that are often involved in chronic disease management. So many different clinicians, and in covering physicians, and in nurse practitioners, and so many pieces start getting into that puzzle, that the puzzle starts getting reshaped. And before we know it, the medications that we thought, from a physician standpoint, our patients were taking, don't match what's actually taking in the home. It's a common problem. And we assume a lot. We assume that you're assuming that we, from the medical side, got it all down. That we have all your medication perfectly aligned, and we caught every drug-drug interaction. And from the physician standpoint, we assume that you're taking the medications exactly as we prescribed them to be. And so often there's a serious disconnect between these two things. So often that, so Mr. Randy pointed out that we've been working together probably close to a dozen years. One of our favorite exercises, so we do a lot of work individually and collectively trying to improve the post-acute care space and improving the care that patients receive that are receiving home health, maybe hospice, palliative care, other chronic disease management situations. And our favorite exercise is to go into patients' homes and get their medications together. And the number of errors and problems, we challenge companies, we challenge programs, give us your best patient that you're succeeding with. And we go in, and they show us their pill box, they show us the med list, and then as we look in detail, we see, well, there's actually 5 pills on Tuesday, but there's only 4 on Monday, and today's Sunday, and the pill box was on Saturday. So something's not right here. This is common. This is common practice. These are serious medications that we're talking about. So, our goal here today is to talk through some of these strategies and how to really look at chronic disease management, how to think about some of our conditions. You know, that writing is even too small for me. Yeah, see, look, somebody's written, the problem is you're over-medicated. Luckily, there's a pill for that. There's actually a comment. You know, this morning, and all my stories are true. This morning, I got a call from my father-in-law, who's having a gout attack. And his knee was really, really painful. And my mother-in-law was saying, is it okay for him to take this medication that he's got, the diclofenac? Well, yes, but how bad is it hurting? What's going on? Why aren't we using regular ibuprofen? And it's a classic example of where individuals receive medications without really an understanding of why and when they're supposed to take it. My mother-in-law's a nurse as well, or at least was a nurse. She's retired now, so if anyone, she should have an understanding of how to think about this. My father, God rest his soul, he would have been, coming up on December, he probably would have been 104 this year, 105. He lived into 94. I had the same conversation with him every week for probably the last 7 or 8 years. He didn't have dementia, but I had the exact same conversation, probably now thinking about at least 8 years. Tylenol versus ibuprofen. We had that same discussion every week. Which one can I take? Which one's safe? I went through it time and time again. Medications that were given at an earlier stage, or for different, and that point that I was making even about my own father-in-law this morning, diclofenac and ibuprofen are pretty much the same thing. One is just a lot more potent and a lot stronger. And both have a real problem on the kidneys. So you have to really cautiously use, I'm going to use my whole family as case examples this morning. My mother, God rest her soul, she passed away at 84 on renal dialysis. But she developed kidney disease because of chronic joint pain. She had bad arthritis, never wanted to bother anybody, so kept taking more and more ibuprofen. Where she was taking so nobody knew it. And before, she didn't want to bother anybody. She consumed so much ibuprofen that it actually destroyed her kidneys, and she had to go into dialysis because of that. This is an over-the-counter medication that caused her kidneys to fail. So this is where I'm talking about, what we're talking about today is important and not to be taken lightly. The case study, oh boy, it's a real challenge here. This is and it's a great example because it's going to relate a lot to a lot of these medications. So I'm not going to call out anybody specifically, but we'll see on a lot of these medication lists, as a geriatrician, so I've been practicing geriatrician for over 30 years. One of the things we use, a term we utilize, is called polypharmacy. Polypharmacy has different definitions by different groups. But most people can agree more than 6 medications is probably polypharmacy. And we recognize this because once you started getting into polypharmacy, the likelihood of drug-drug interactions, the likelihood of one medication causing an issue with another medication starts to go up considerably. So you start getting a lot of concerns once you get over 6 medications. So as I pull up, we can see, I I don't know how many lines are on a little tablet paper anymore, but it's certainly more than 6. So without even, not saying it's wrong, I'm just saying we have to be cautious. So in this case, this was Anita Lesmed, admitted to home care services after a recent hospitalization for pneumonia. History of osteoarthritis, falls, chronic low back pain, nothing too striking here yet. A little bit of shortness of breath and difficulty with walking. Well, she's getting older. She's got diabetes, has a neuropathy, has some heart disease, actually had a heart attack 6 years ago, had bypass, has a little bit of cardiomyopathy, a little bit of a weak heart following. This is a common scenario for an older individual. Well, let's look at her meds, like it says. And it's a lot of medications. Lipitor, Lasix, potassium, Aricept. I think that says, or it might be metoprolol. It is. Okay, very good. All right, there's our ibuprofen, some sartan in there, metformin, glyburide, insulin, aspirin, diphenhydramine, Coreg. I mean, we can go through, it's a lot of medications. There's a lot of medications here. And this is because this is an individual who is seeing a cardiologist and getting on guideline-directed medical therapy from the cardiologist because they know what they want to do for this individual. They're likely seeing an endocrinologist because they're diabetes and they're trying to maximize their diabetes treatment. We have low back pain, osteoarthritis, high blood pressure. There's probably a neurologist involved, so we have some Aricept, we have some Alzheimer's medications involved. There's probably the primary care doctor who's addressing some of the more nuanced, less serious issues that they go to the doctor for. And a lot of times, as I said, individuals aren't talking. This is a classic example. So right up here, what hits me first and straight off is the Aricept. Cognitive impairment, these medications, Aricept, amantadine, these are commonly prescribed medications. In a nutshell, the theory behind why the brain dementia occurs is because there's a specific neurochemical that gets depleted due to the disease, and as we age, there's less and less of it. That neurochemical is called acetylcholine. And so the prescribing theory right now is that if we can give medications that increase acetylcholine, well, we'll make a person with dementia better. I don't know if anybody has, we can gladly discuss Alzheimer's, dementia, all the related dementias. I used to be the director of the Cognitive Disorders Clinic at the University of Texas, so I'm very well versed and familiar with this disease. The medications as a whole don't usually do what we hope them to do. But just on the very basic level, they're trying to increase acetylcholine. They're pro-cholinergic. Well, the Myrbetriq that's over there, that the primary care doctor gave because the patient went in because of urinary incontinence. She was having too many episodes of weak bladder. And so they put her on a medication to help that. Except for that medication is a anticholinergic. It depletes the acetylcholine levels in the brain is its mechanism of action. So this is just, and this we see all the time. It's just a classic example of how what we're trying to do with one medication is completely being offset by another medication. It makes no sense for those two medications to be given to somebody at the same time. Yet we see it all the time because this type of reasoning, we don't see the full picture of medications. And oftentimes, we're not going to the doctor. Everybody brought these type of, they wrote out these instructions, these list of medications based on instruction for Randy. However, what we know and what I know from managing complex individuals for many, many years is the person who's going to be most successful in their long term. And what do we mean by success as well? As my definition for success means you get to live healthily for as long as possible in your home. Not in, most of my practice is in a long-term care facility. I've spent decades in nursing homes. They are difficult places to be. I don't know if anybody has a family member or relative in one, or visits or volunteers. I love them because of what we try to do and what the needs are. But from a personal aspect, you don't want to be in a nursing home. Actually, I forget the statistics right now, but I think we're looking at probably 38%, 42% of all individuals are likely to spend at least some time period in a nursing home. So we want to do everything we can to stay out of that type of facility. They're difficult places to spend our lives. So happily, healthily, out of nursing homes, and then the other one, out of the hospital. Hospitals are tough places as well. There's brilliant things going on. You get wonderful treatment, but it's also places where lots of things happen. So I want you to stay home happily, healthy. That's what we mean by success. If we want people to be successful at home, when I have family members that are really driving towards that, one of the things they always do is I reconcile medications. I go through, just like we saw in that last list, I get to match up. This medication doesn't make any sense with this medication. It's because I have a list of medications. So if you don't have a list of medications, it's probably the most important thing. If you walk away from this talk with nothing else, you have a list of medications of what you actually take and when you take it. And you need to take that list to the doctor when you go. Because very often I sit there with a patient member and I'll go through and I'll start going through their list. I'll open up my electronic medical record system from your last hospitalization and I start going over your list of meds and I'll usually have a daughter go, that's not what mom's taking. This is what mom's taking. And if they have that list, then I'm already keyed in. This is somebody that's likely going to be successful. However, most of the time there's no such list. And we're working off the EMR system, which is not usually correct. So, as we start really getting into the medications, where to start is you have to be a champion. You have to be a champion for your own health. To that end, some of these practices, they may seem laborious, but it's important. They need to be done. And there are 7 little key areas that do need to be done. Number 1 is gather all those medications together. What people consider medications and what needs to be discussed doesn't always match up. For instance, I'll ask people to tell me all the medications they take. This is the most common one that occurs to me, and it's surprising on this medication. So I'll sit down, I'll go through their meds, I get all their medications together, and I'll say, is this everything you take? Yes, those are all my medications. And then there's 3, maybe 4 places I love to go take a look if I come into your home. I look in your refrigerator, because there's usually medications that need to be kept cool, so I find other medications there. I look in your bathroom for safety reasons, which you may have had your talks about, but I also look in the med cabinet in there because there's other pills there. Because I usually ask people to get their meds all together. And then I look at your bedside table where you're sleeping. And there I always find a pill bottle. And the most common one I find there is called Seroquel. And I get the response of, well, you didn't tell me about the Seroquel. And they say, oh, well, I just take that for sleep. Well, it's a medication, 1. Number 2, some medications have what's called black box warnings. It has a black box warning because it has a higher incidence of morbidity and mortality, death. It has a risk of increased death from taking it. It has serious, serious side effects. I'm always amazed how often I come across this medication and I'm just told it's for sleep. And the fact that you're taking such a life-threatening medication so casually is very, very concerning. So get every medication together. Throw away the old medications. At least, they've been 3 or 4 years since then. Get rid of them. It just runs into problems or complications. Make sure all the medications are on that list, even if you kind of just take it just for sleep. Or if you just have multivitamins, because there are vitamins and multivitamins that interact with strong medications, with other medications. Make sure everything gets put on that list so when you go to your doctor, you can reconcile that list. So that's the first step, that's the main takeaway. Everybody needs to have, if you take more than 6 medications, if you take more than 4 medications, you really should have this list. You should take it to each of your doctor's appointments. The doctor should see that every time he goes, and that way his list can match what you actually take. Because again, so often it doesn't happen. Oh, we're going to challenge my reading here. So, as we said at the first point, have your doctor look at the list. It may be a surprise. Some of these points are the doctor's not used to it. The average primary care doctor isn't used to having patients come with lists. They're also not usually used to you asking questions about your medications. It doesn't matter, it's important and you need to do it. But don't be surprised when the doctor might be surprised that someone's doing this. Most of the patient population takes things just as gospel. My doctor ordered it, therefore I have to take it. And that potentially can be risky at times if everything's not reconciled and if everybody's not talking to everyone else. Have your list of questions prepared before you go to the doctor because it can be delays, fast in and out, overwhelming experiences, lots of things discussed, and your main points don't always get discussed. So make sure you have your questions listed out. The next point that we have here is, what should I be monitoring for as far as my medications? So every medication has an indication. What is that indication? So if we take blood pressure medications, you should be periodically looking at your blood pressure. If it's been stable for a while, it's not something that has to be done 3 times a day or even every day. Maybe once a week is all we're doing. But periodically, you need to take a look. Your body changes, medication changes, conditions change, and it's worth keeping some type of log about what's going on. Most importantly with blood sugars. So there are some things, for me, as a geriatrician, that are my bread and butter. You know, if you are a pediatrician, the ear infection is the bread and butter for a pediatrician. So it happens just so often. Kids are always in ear infections. As a geriatrician, my 2 bread and butter conditions are hypotension and hypoglycemia. Low drops in blood pressure and drops in blood sugar that lead to falls and injury and confusion and other side effects and complications. It happens so frequently. So again, we can't just take these as gospel. You need to know what you're monitoring as far as each medication goes, and keep some type of log. As Randy pointed out, I do a lot of things on a larger level. We did a pilot study with the University of Ascension, Indianapolis, looking at congestive heart failure patients and their monitoring of their conditions, and especially monitoring. Just within the first 4 weeks, we had roughly 30 patients that were in the program. When I looked at the data of those 30 patients, heart failure at home, coming from a specialty clinic, only 7 of them were doing any type of weights, and only 1 of them on a daily basis. From where I sit, that was catastrophic. The most common, the most identifiable way of catching the problem with heart failure is sudden cardiac death. 1, individuals can just pass from it, and 2, acute decompensation. People go into heart failure potentially within hours. But we know, leading up to that decompensation, there's almost always a weight gain. Almost always a weight gain that can be caught. So daily weights is a very simple way of monitoring a condition and capturing it early. But people don't do this. And very often, then by the time you're coming to the emergency room and then I'm seeing you in the hospital, we find that your weight was up 5 pounds over your baseline when you're in the hospital. This could have been seen, this could have been caught. This is coming out of a specialty clinic, they're not doing it. So the monitoring of your condition is not something that most of your doctors talk to you about. If they have, fantastic. But most of the time what we're finding, it's not occurring. And it's something you can do significantly to make a difference into your health. whatever your condition is. If you have COPD, it's monitoring your breathing, it's monitoring your cough, it's monitoring your mucus. It all has a meaning. And just keeping simple notations of what your condition is like can be incredibly valuable. As I mentioned, our bodies change with time. Just because a medication was ordered once doesn't mean it's always the right medication and that it's always good. As I stated, I can be able to give this whole talk with just my family, it sounds like. So this is me personally. I mentioned it. We're going to get personal a little bit, so I'm going to get a little personal. I mentioned this to my wife this week. I've been lucky that the last 7 years, my allergies have been almost non-existent. I moved to Tennessee for a few years in the role, and then they allowed me to move back from COVID. It's a whole other discussion, but I had terrible mesquite, oak, mold, everything else that flourishes here in Houston. And just half the year, I'm constantly, my eyes are itchy, my sinuses are congested. It went away. And even when we moved back to Houston 4 years ago, the last 3 years have been tremendous. Except this year. The last 2 weeks, I have been in just agony, nasal congestion and itchy eyes, just like I remember, just like all the bad days before. So finally, it got too much, and I started I do what we all do. I went into my drawer, pulled out what I had in there, and tried to see what all the stuff, all the pills, and most of them were in boxes, and looking at it, and just start taking what's going to probably be the best for my sinuses. And I grabbed one that's a Claritin, and I took it. It was Claritin D. I didn't pay attention to that when I started taking it, but it was Claritin D. And on the third day, I woke up in the middle of the night, which I don't usually do, to have to go to the bathroom, and I had a hard time going to the bathroom. And I was like, oh my God, what the heck? And sure, I thought about it, and sure enough, I looked at the bill, it was Claritin D. I wasn't paying attention to what I was taking. The pseudoephedrine that's in the Claritin D with older individuals affects prostates. And that's why older individuals should never take regular sleeping medications, certainly older men, because the sleeping component in over-the-counter medications is Benadryl, and Benadryl is one of the worst for older men. How we were before isn't always how we are now. And things change, and we have to be very aware of this, certainly as we think about medications. Our goals change, certainly about medications. Your goals change as we're 80 or 84. It's very different than what our goals were when 75. And we have to take that into consideration with the medications we're taking. Is the problem the drug was prescribed for still a problem? A lot of times medications get added on, they never get taken away. A great example, and I haven't looked at these lists, but proton pump inhibitors. Prilosec would be one. So as soon as you come into the hospital, we know that there's a stress response from hospitalization, where people can get acute GI pain, stomach irritations, just from the stress. So almost everybody, standard of care, as soon as you come to the hospital, they're going to start a Prilosec. That doesn't mean we needed it. We started it to prevent the stress response. But very often when you get discharged, it hangs around. And then people are taking these medications for years sometimes. And actually they're problematic even on themselves. Even when somebody has an ulcer, you only indicated to take it for 3 months. Yet I find most people on proton pump inhibitors have been taking them 1, 2, 3 years. And there's problems because it decreases the acid in your stomach, which actually increases the risk for pneumonia. We would never realize that. There's a strong correlation to taking proton pump inhibitors and pneumonia. Again, bread and butter in my world, urinary tract infections and pneumonias happen so frequently. Dental care becomes so important as we age for that very reason, to try to lessen the risk of pneumonias. So a lot of times when medications get put on board, they're not really still needed after a period of time. Are we having potentially problematic side effects? The kidneys and liver age. The kidneys age. And we have to be very aware that kidneys get weaker and medications are strong on the kidneys. Ensuring that the medications are taken as intended. Well, we know from studies, 40% of all medications, prescriptions are never filled. That's an astounding number. 40% of prescription medications are never even filled. And then when we look at the studies of how often there are errors when people take it, so that's part of a lot of the work that Randy and I do, is looking at the medications. We find medication errors almost 100%. Almost in every household we go into, we find something is being done that's not how it was written on the prescription. Or they're taking it differently, or they're not taking it when they were supposed to take it. It's a classic example. I went into a home once, and we were reviewing, it was a heart failure patient again. It was 11:30 in the morning, and as I was reviewing everything, the patient finally, with the daughter, who was very proud about how she was doing with her mom's management, and then mom said, "Why haven't I taken my morning medications yet?" Well, it's 11:30. When were you going to take it? Well, it was a slow day. She was getting started. She was going to. People are not compliant with their medication, and it potentially runs complications, especially when they're on 3 times a day medications of the same medication, which she was. So making sure that medications are taken as prescribed. What's on the bottle should be what you're taking. If you're not taking the way it's on your bottle, you need to make sure your doctor is aware of that. Additionally, having some type of system in place for how you take your medications is also extremely important. So I've only just started taking a medication called allopurinol, also for gout. And I'm good maybe 5 to 7 days a week. I miss it currently twice. That's the only medication I take. And I'm good maybe 5 to 7 days a week. It's hard taking a lot of medications every day. Certainly when we get to twice a day, 3 times a day, maybe some people are on 4 times a day medications of different medications. The likelihood of you not taking it and having a missed dose and missed errors is extraordinarily high. And people take it for granted and don't realize how often errors in their management and what they're taking, how often it actually occurs. How often they're not taking the medication, they forget, like taking that bone demineralization medication that you're supposed to take with a 6-ounce glass of water on an empty stomach and sit upright for half an hour after you take it. All of that goes to the wayside really fast, really soon. So take your medications as they're prescribed. Ensure precautions and restrictions are followed. There's guidance around your medications. Make sure we're following those restrictions, we're following those precautions. Again, just like sitting up afterwards, after we take that medication. There's a reason behind it, not to inconvenience you, it's because there's a higher rate of erosive esophagitis when you don't do it. So when you don't follow the reasons behind it, errors come up frequently. Keep a record of what is happening. So that gets to that variance that I'm talking about. With blood pressure, so if you're 55 years old and you're on an antihypertensive and your blood pressure is 110/70, fantastic, I'm going to say. Keep doing a great job. If you're 65, I'm probably going to say, fantastic. Keep on doing such a great job with your health. If you're 85 and you come to me with 110/70, I'm going to say, uh-oh. Now it's the exact same blood pressure reading. Because at 110/70, and now at this age, what's going to happen is what I see all the time. Somebody's going to drop something, or you have a pet, which I find always gets overlooked. And why I'm saying pets, not because they're going to get in the way, it's because they have water bowls and food dishes. And people do this, and bend over, and as soon as they come back up, because of that blood pressure of 110/70, when they bend over and try to come back up, the pressure's now 90/40. And all of a sudden they get lightheaded and fall back. This usually occurs, and this happens so often, in the bathroom. People wake up, they take their morning medications, have a cup of coffee, go to the bathroom, and all those combined effects dramatically drop the blood pressure. And that 110/70 is too tight a control for someone who's 85. And sure enough, after they went to the bathroom, their blood pressure is low, and they're bottoming out, and they're falling over, and everything in the bathroom is hard. The sink's hard, the shower's hard, the doors, the toilet, the walls, everything's close by, everything's hard, and I see lots and lots and lots of injuries behind that. So keeping a record of what's going on so the doctor can review that record and make appropriate adjustments. And very commonly, that individual is on multiple blood pressure medications. And at times that blood pressure, you start seeing the recordings, 98 over 50, and everybody gets excited because it's such a good blood pressure. Depending on your age and circumstances, it could be a dangerous blood pressure. Oh, there's no way I can read that. Anybody read the ring? Ah, okay. Yeah, make sure you're reviewing. So as I said, with everything that you're going on with your chronic condition, make sure you're reviewing it with your doctor about what should I do. That's so often not reviewed or discussed. And a lot of times the doctor's response is, give us a call. Well, you're not open after 4:30 or 5 o'clock when you have the problem. Or I sit on the phone I'm waiting for 30 minutes to an hour to get that response. If your blood sugar is too low, or I have the symptoms, which are what, doctor? What should I be aware of? And he should go over those symptoms. What should I do? Because that so often is not ever done. And, you know, again, myself and my colleagues, we make a living doing hospital-based medicine. And everybody in the hospital has a story. And almost every single one of them have the exact same story. This was going on for several days until. And it's that until that brought you to the hospital. And very often, there were things going on that they were aware of, but didn't know that was a problem related to their condition. And should have known, based on what the condition, that should have been something you took action on. That we could have done something sooner to avoid the problem that then led to the hospitalization. And hospitals are packed full of individuals right now. So ask your doctor, what do I do if? So there's a plan on what to do for what you're monitoring. So some of the keys to success from what we discussed. You have to be a champion and take control and take charge of your medications. You have to organize your medications, getting every medication, every pill, every vitamin, every sleeping aid, everything together. You have to write it down. You have to have that list that you have to then take to your doctor so he can reconcile. You have to make sure you're taking the medications exactly as they're prescribed, following the restrictions, and you know exactly what to monitor and how to respond to those variances. I know there are individuals here with chronic pain, diabetes, hypertension, heart failure. Every one of those has a regular monitoring component that should go with that medication that you should be doing on a consistent basis. And the fact that you haven't had a problem yet is fantastic. But as we said, I was great last year until I took that medication this year. And things change as we age. Our bodies change as we age. Our bodies don't break down medications as they used to. They have to start to affect other organs that we forget about and were never a problem before. I forgot about the prostate, and my mom certainly forgot about her kidneys as she was taking those medications. We forget things as time goes by, and time goes by too fast, and it's such a shame to spend that good quality time away from family, away from friends, and in hospitals, and God forbid, in nursing homes, where if you have to be there, I'm happy to take care of you and do a wonderful job at it, but it's not where you want to be. Quickly, some individuals were fortunate to just pass some medications. I can't tie names to them at all anyway. It's just like, for instance, I'll do a quick run through on one of these, thyroid, Celebrex, vitamin D, metformin, gabapentin, a statin, Repatha, Jempibrazole, duloxetine, Plavix, Olmesartan, Ozempic, and Tylenol or Brita. So just some things that come to my mind from looking at this is the vitamin D is a low, it's only once a week, but it's a low amount. So review with the doctor, is such a low amount once a week right? Should I be taking more? Should I be taking more, maybe less frequently, maybe a larger dose every 2 weeks? You can take very high levels of vitamin D. We don't get enough vitamin D as we age. The best way to get vitamin D is from the sun. So if you spend a little bit of, your body will make vitamin D very fast. And it stores it very well. So getting some sun exposure. But if you You're not getting any sun exposure, taking the supplement. And what was your level? The levels of vitamin D that are reported as within the therapeutic range are really too low. They need to be higher. So most of us take higher levels of vitamin D. We're on 2 glucose medications, so we have to be very concerned when we take 2 about bottoming out. So we want to make sure we're checking it once in a while. Statins are one of those medications that are great. There comes a point in time when we can decide maybe I don't need a statin. Statins are associated with lots of side effects as well. At what age do we decide there's a legacy effect to a lot of these medications? Statins are one of these. And a legacy effect, I mean, once you stop taking it, the body still gets its benefit from taking it for several years. The legacy effect for statins is probably about 4 years. So once you take it, you still get the effect. So if you're 85, you may decide, maybe I don't need to take that additional pill every single day. It's just an opportunity to discuss. But the rest of them are okay. I always caution when I see the Celebrexes, the diclofenacs, anything that's a non-steroidal drug, they're hard on the kidneys. So at some point in time, we need to really make sure we're watching that kidney function. I'm going to just jump over real quick. Eliquis, losartan, and amlodipine, metoprolol, montelukast, another statin, famotidine, levothyroxine, alendronate. Well, there's one of that medication I talked, so make sure we're taking that medication as prescribed. Full glass of water on the empty stomach, remain sitting upright. We're on 1, 2, 3 blood pressure medications. So we got to make sure we're watching that blood pressure. We got to make sure we're not too low and bottoming out. Otherwise, the medications all look good and no over concerns there. Azole, Crestor, aspirin, iron, vitamin E, multivitamin. So this is just where it's great to take supplements. We just have to be, make sure we're taking the supplements for the right reasons. Anytime somebody's taking iron, iron can be nauseating, certainly in the nursing home population. This is one where I always argue too with family members because they really want their loved one to be taking these supplements. Iron is very nauseating and very constipating. And what happens in a long-term care facility is you get your meds are all given as the medication the person comes by. She starts at one end and has to get to the other end. And in between, breakfast is going to show up. Well, where are you in that breakfast flow? And if you're getting all your medications 30, 45 minutes before your breakfast, by the time, and I see this so often, by the time breakfast shows up, because that iron and multivitamins been sitting in your stomach for half an hour, you're too nauseated. And people usually push their breakfast away. They don't want to eat. And then we blame it on, well, mom's getting old. She just doesn't eat. No, you're making mom feel terrible right before the biggest meal of the day. Let's get rid of those medications so they don't impact her eating. So make sure if we're taking these medications that we really do need them. Inhalers, vitamin D again, a lot of allergy medications. Yeah, a lot of allergy medications. Tramadol as needed. So tramadol is one of these where we thought, what a great medication. Non-opioid, non-anti-inflammatory, it potentially has side effects, and the whole profession is rethinking the use of tramadol on its potential risk for morbidity and mortality. So it may not be the safest medication for chronic pain. But if we're only taking it as needed, probably not as concerned as if we were taking it several times a day. But as time goes on, these as needed become daily, and then twice daily, and then 3 times daily, and then we potentially have real problems. But nothing overstriking in any of these lists here, although they are a lot. So it's always, the other point that I always get to is how we organize multiple medications. We have tons of pill bottles. How do you keep track? And I see this all the time too. Well, how do you take these medications? And they literally sit there with their shoebox at breakfast, lunch, and dinner, and they go one by one. I took that, I didn't take that, I take this. You know how often that leads to errors, it leads to a lot of errors. So, again, I'll end here. I appreciate everyone's time. There was nothing rocket science or revolutionary that I presented to the group, but I just want to let you know from a day-to-day activity, this is the stuff that is the bread and butter of medicine. This is why most people end up in hospitals, is due to adverse events with medications. You taking control of your medications and doing some simple steps of creating a med list, taking it as it's prescribed, having some system in place so you take your medications accurately, that you review that medication list with your doctor. Don't presume that he knows exactly what you're taking, sort of that list, because what he's looking at in his system very often isn't what you're actually taking. Monitor to some degree what's going on with your condition. Take those results to the doctor and know how to respond to the variances. Just like my father this morning, I ended with that one. My first question I asked was, well, how bad is the pain? Because if his pain is only mild, why do we need to take diclofenac? Why take such a strong medication? Can't we take something milder? So reviewing that with the doctor. If I have mild, whatever, mildly low blood pressure, what do I do? If I have a significantly low blood pressure, what do I do? If I have a blood sugar of 50, what do I do? If I have blood sugar that's coming back as 40, I don't want to go lower because it starts getting really problematic. If I have a blood sugar of 250 or 300, what do you want me to do? You should review all this with your doctor and have a plan in place for all the conditions and what you do when, how much of what medication for that situation. Please. Well, you need to make sure it's reviewed, is one. And because it's in the system, the cardiologist may be looking, he's really zeroing in on something else at the time and may not be as concerned about another level. So even though you have their eyelids and everything looks fine, that's very common doctor speak right there, everything looks fine. Everything looks fine from their perspective of what they're wanting to see. I think. Okay, so for me, that's that red flag. What's a little bit low, doctor? What's a little bit low, and when do I get worried? When should I be concerned? Because maybe it was 3.2, you get the potassium level. It's a little bit low, but it's okay. But am I trending down? Should something be done? What are some symptoms that I should be worried about or concerned about potassium getting too low? And maybe I need to review how I'm taking my diuretic, because we changed my Lasix to 3 times a week, and we stopped my potassium when we did that. So I'm not taking potassium at all anymore. You may not know that. You may have just decreased the Lasix and forgot about your potassium level. And so your potassium is on a downward cycle. Because what I needed to see is when you come to the hospital and you're having arrhythmias and your potassium is 2.8. Because it was trending down. So if everything was okay, when? Make sure you're very clear on if he has any concerns, what would make him more concerned? Is there anything else I should do? We don't ask these questions enough in our offices. And doctors are very quick. When we see the lab, they look at the kidneys, creatinine's fine, potassium's fine, and we move on. But, well, it was 3.4 last time, it's 3.2 now. What were those lights? Make sure we're asking, make sure we're getting specific. Yes. Depends. So that's where it becomes very unique. One 80-year-old is very different than another 80-year-old. So that's where it starts making a difference. So if it's an 80-year-old who is driving, power walking, working, then I want still good blood pressures. I want them in the 120s, systolic range. I want those diastolics in the 70s to 80s range. I still want pretty good levels. If we're 80-year-old and we're gardening, that to me is already a concern because the sun is bending over. Maybe I don't want those same levels. I want to be closer to the upper 120s, 130s, 80s. I don't want to. It starts my window. It's very non-specific. It really has to be tailored to the individual person. Yeah. What's going on? What are you doing? What's your lifestyle like? All this should be taken into consideration. I think we're ready to help. I think we're right on track. Thank you all.
Dr. Mills, it's such a good to have you here. I want to say something as you're making your way over to lunch. One of the things we want to do is try to equip you with the questions so that you, when you're going to your doctors, you have a questions to ask. And so today is just the tip of the iceberg of the training. And we'll have a minister who is more deeply trained in this.